So we have gone through many sessions and we have been concentrating mainly on physical aspects. Now we are going to psychosocial aspects, which is very important, not only in palliative care but in any other specialty. So, Mr. LITHIN ABRAHAM, who is the senior social worker who is working with us, will be handling this session. LITHIN, so over to you.
Good afternoon, all. My name is Lithin, as it's already been said. So I'm a senior medical social worker working here since 1.9 months. Sorry, 1.9 year. So today the sessions that we're going to take is about psychosocial care. So I think basically you may all have a knowledge about what psychosocial care is. So the very definition of health itself given by WHO says that it's the well-being of an individual, not just merely a disease or some difficulties, but we had to concentrate upon the well-being of an individual. So particularly, we had to take care of the physical, psychological, and social factors. So in the same way, though at most of the times we tend to look on only onto the physical aspects. So here we are going to look on how we can take care of the psychosocial aspects also. So the World Health Organization has defined palliative care as an approach which improves the quality of life of a patient and their family. So we just don't look at the patients, but we also look at the well-being of the family too. So as you all would be knowing that palliative care is basically for people like who are associated with life-threatening illness and maybe like they are reaching their like end of life and all. So what we try to basically do is to in order to do a palliative care assessment, basically our primary focus is to like prevent the suffering that they are going through. So preventing suffering means we have to be with them. So we don't know what suffering they are going through. Though that suffering could be physical suffering, that suffering could be psychological suffering, that suffering could be social suffering, it could also be a spiritual suffering. So we need to know what the suffering is basically. So the best thing that how we can know about it is to communicate with them. If with proper communication, we will be able to know what suffering are they going through. So why is psychosocial care important? So as I already told in the definition, when we talk with a person or with the family, maybe that person would be going through not just physical issues, but that person would be going through also some psychological or some social issues too. So most of the times we tend to ignore it, but if we try to identify it, and I think that we can provide a better care for that person. So the other thing is that I'll tell you an example. Like let's take a person who is a young person, nearly like 30-35 years old. So that person is working in a good reputed company. He is married. He has a couple of kids, and suddenly one fine day he had a small pain in his body. He went to a doctor. So the doctor, after the diagnosis, happened to tell him that he is having a disease which is life-threatening. So the next thing that comes to his mind is because like being a person who is only 35-year-old, he has a lot of ambitions in his life. He has a lot of things to do in his life. He knows that my life is very open to me. I can do whatever I want, and he is trying to make his family better, and he has like a lot of aspirations in his life. But when he hears that he's having a life-threatening illness, slowly all his aspirations, all his ambitions come to a standstill. So at that time, so whenever a person is approaching death, there are unique stresses that that person is having, and there are now his life. Maybe yesterday his life was not having much challenges, but from today, the time that he heard it, he's got a lot of challenges which he has to do in his life. So basically, we can do is like to be what we can do is we can sit with him and talk with him, and we can understand the factors which is getting affected, and we can try to improve his quality of life. So we have, the most important thing is that we need to know just not just his physical problem, but also maybe his psychological, social, and spiritual problem too. Because death is something which is inevitable. We cannot say that a person will not die. If a person is born in this world, it's definitely that person is going to die. So what we can do is that we can provide a help, we can provide a care, and we can help that person to die better, so that and his family would be safe. Uh, like we can make that family safe by understanding the factors that he's suffering from. Okay, so the assessment that we do is not just on one aspect. We do, as I already told you, on all these four aspects, which is physical, psychological, spiritual, and socio-economic. So I've been saying about this for quite some time. So we'll know how we are going to do these assessments. So in psychosocial assessment, what we do is that we need to take an accurate, detailed assessment to know what the factors which is affecting the well-being of that patient. Not only for the patient, we also have to look on what the family and the caregiver is going through. So as I told an example, maybe that person knows that he's going through some challenges. Now his family, who were like they were like quite independent, now they also have to be always available. Maybe a working person in the family has to be always there, available to take care of the person who is not well. So they are also getting affected psychologically, maybe emotionally also. They are very much challenged. They don't have anybody to share their inherent feelings, so and emotions. So they are also like, how if I say something to this the person who is not well, maybe he or she may feel bad. So likewise, like they are having quite a lot of challenges, and they also would be worrying, like maybe the spouse would not be much educated, and also they would be thinking about how my life is going to be in the future. And so what happens is like, uh, the next at most of the time, what a normal family does is, when they don't they try, because like human beings always try to get some help from the nature or from the surroundings. When they feel that they have no help, or no help from the surroundings, or no support from the surroundings, the next thing that they do is that, so because now, for example, if this person, if maybe the family would be just depending on the income of this person who was working. Now they don't have any other source of income through which their life could sustain. The next thing that they often try to do is like, why don't we end our life, and why don't we do a mass suicide in a family? So likewise, they normally it happens on. So what we can do is that if we try and go with them, just as we say that we can, if we can understand the suffering, we can just be sit beside them, talk to them, listen to them what the problems are. I think that most of the by listening itself, maximum of the problems we can understand, and I think maximum care we can provide to them accordingly. So in this assessment, what we personally do is that, on the basis of the experience that we have over here, what we do is like, we tend to collect as much information as we can get from them. And when we collect the information, we also try to know like, what all the strengths they are having now. Even in this situation, they may be having certain strengths, and what all resources they are having, and basically what needs they are having. And the other thing is that, when we initially we take a initial or a primary assessment, so we get a lot of information. So it doesn't mean that we have to stop our assessment over there. Maybe we can say that, yeah, it's done and it's completed. It's not so. Actually, it is an ongoing process, because today's needs are not the same needs which that person may have maybe after 2 months. So this assessment has to. It's an ongoing process. So because like, yeah, as I already told you, it changes over the course of the illness. And what we in while we take the psychosocial assessment, or while we do the assessment, what we tend to do is that we just don't look at that person as a person who is a patient. We try to go beyond that to know how they are, how what their living experiences are, or how they are coping with, and all. We'll try to understand it, which can be much more helpful. Basically, what we can do is to build up a good rapport with them, so that in the course of the treatment also, it could be very helpful for us to help them out. So my patient does not experience the physical and emotional symptoms separately. As I had already discussed with you, maybe person would be having huge pain in his body, as well as maybe that if normally the examples which I give to some of the patients which I see when I tell them about palliative care is like maybe the pain that the physical pain that the person may be having would be 20 or 30%. The other pain, that maybe the psychological pain or the social pain, maybe this person was a very socially active fellow, so now he is not able to go out, he is not able to mingle out with people. So what he feels is like my life just is now confined into the four walls of a room. So now I'm not able to go out and do things as I used to do. So that is something that so maybe that could add on to another 40% of the pain that the person is going on. So if we tend to only look at the physical pain, maybe we may be able to reduce the pain with the help of an opioid. The 30% will go, but the rest 40% is still there. So if we can completely understand that person's pain, then I think that maybe you may have already have gone through a class which talks about total pain. When we can try to understand it, I think that we can provide a better care to that person. Okay, so while we do psychosocial assessment, there are in two ways we do it. One is purposeful observations and purposeful conversations. In India, we have like almost 29 states, if I'm true, and in every state we have different cultures. So in all these cultures, all the things when we say about death or when we talk about certain things, everybody understands in their own in their own. For example, I can give you uh, I cannot build a good rapport with a person with who is living in another culture. I cannot understand him on the basis of the culture that I am living in, because in order to understand him, I need to know what cultural differences we have between both our cultures. Only on the basis of that will I be able to go and talk with him. So it includes a purposeful observations are also purposeful conversations are also needed. So, as I just pointed out certain things, it includes the patient's cultural and religious beliefs, preferences. It's not that we been taking care of a lot of patients. We should not say that this is better for you. You should do this. It's not so. What does that person think? We have to we have to put ourselves into the shoes of that person, and we have to know like what that person prefer in this situation. That we can do. We can understand if they have any particular fears or any phobias, any particular phobias they are having, or any grief they are having, and how do they view their quality of life. Because I believe that every person's quality of life is different. My quality of life is not very much not as it would be of another person. My quality of life, how I want my life to be better, it depends on my understanding. So we need to understand what that family's quality of life is. So maybe we can, maybe because of the pain, maybe because of the trouble and all, the family relationships could be affected. Maybe that would be some one sort of grief which would be going in through the patient's or through the family's mind also. And also, like one thing that we make sure in palliative care is like we always try to know whether they understand about the diagnosis and whether they understand about their prognosis. So that I think that is very important. Understanding from the human being's perspective, that person should know what he is going through, or and like maybe with the reason why we try to make sure that the person knows like maybe uh, that person would be nearing to his end of life, and maybe that person would be having certain desires in his heart which he wanted to say to someone, or maybe he wanted to like maybe drink as we say Ganga Jal, and so something like that, we don't know, so something like that that person may be having. So we need to like make sure that that person is understanding, or maybe to write a will for the family, for the children, something like that. I think it can be very much helpful for them. Also, we can understand if they are having any suicidal thoughts or not. Okay. The next is spiritual suffering. In spiritual suffering, we just don't tend on to say about like your belief in God. Whether are you a Christian, are you a Hindu, are you a Muslim, are you a Jain? We don't tend to do that. What we try to basically know is that what does the patient describe about their spirituality? How do they describe their spirituality? We ask them, and what are their faiths and what are their beliefs. It's not necessary that there should be an aspect of God in it, but an image greater than them. It could, maybe it could be a person, or maybe it could be a community in which they are living in. It could be anything. And also in spiritual love, we try to understand what are their expectations and how do they cope up with the present situation they are going through. So we have a tool. Actually, it's taken from the Journal of Advanced Nursing. This means reproduced by Wilfred McSherry and Linda Rose. So they have presented a tool through which there are certain questions in it. So we can like ask these questions to the patient, not exactly as it goes, by building a good. I believe that after, if we cannot build up a good rapport with the person, I don't think that we will be able to. It all, as we already said, that it's an ongoing process. So we take all this assessment as the days go on. We don't just sit on one day. We have 1 hour, so we have to just finish it out. It's not so. It depends as the days goes by, as we get more close to the patient, as we build up good rapport. We try to talk on with them. So basically, in this, what they have said is like we try to understand the connection. Like as I already told you, maybe the person or the community in any other persons or any other community, maybe that person wants to see anybody, maybe a long lost friend, maybe they had shared a good time with them. So if they want to see them, or a community which can support them, something like that. So we can help them out with this. And also meaning and joy. What was the most meaningful thing in your life, or what is the most thankful, what are you most thankful for, or what makes you more happy? So to just cite an example, I remember talking to a patient in my work. So I happened to ask her like, what is the most, what are you mostly thankful for? So what she told me is like, she has only one daughter. She told me is like my daughter's birth, my daughter's growth. Now the daughter is quite like old. So and her career, her life, her growth in her career, that was something which has always motivated me, which has always like helped me out. So so that she's actually very much thankful that she was able to provide so much for her daughter. So it depends upon person to person, like what, how do they understand the meaning of their life, or what is the greatest joy that in their life they have. So also we can also know the strength and comfort. What are the things that like they may have some strengths within themselves, so we can understand what are those strengths, and maybe that strength could be one of the greatest comfort also for them. And basically as it's already said, like hope and constancy, what are their concerns, and if they have any particular hopes, basically we don't try to give any false hopes, but what are their hopes and concerns, we try to understand it. Okay. The next is the socio-economic assessment. So we have a socio-economic assessment sheet over here. So in that, how we try to understand the socio-economic status is like, we try to know who is the breadwinner in the family, and what is the source of income, whether they are having any particular debts, any loans they are having which was being taken care of, the patient of the by the person who is now affected with the disease. And what is the status of the education of the children, in which class are they studying, whether they are able, whether the children are able to go to studies, or have they stopped the studies because they have to because there is no finance available in the family to look after their studies, or are they working. So we need to understand, like, what is the education status of the children also. We try to do that also, and we try to know the dependence. We draw a genogram, and that we mention about all the dependents and all. We circle it. So we try to know who all are dependent on the patient. And also, if they are not getting any particular schemes and pensions, I believe that the government has provided quite a lot of schemes and pensions for people out there. So I think, if they are not getting it, if we will try and will help them out to get it, so that with that it could be helpful for them in the family. So the interventions that we do is like, we conduct family meetings. Maybe if there is any difficulties in the family or dysfunctions in the family, we try to call up the family. We sit with them. We talk with them. We try to we don't give solutions to them. We try to find out solution from them itself. From them itself, we'll try to ask them to find out solutions for themselves. So we do that. We give supportive counseling. If any help is needed, any support is needed, we'll do that. And cognitive behavioral based communication we do. We try to understand what is going on in their mind. We'll try to understand, like, what uh, any are there any change of pattern in the behavior patterns and all. Then facilitating psychoeducational support groups, bereavement support, which we do. Actually, bereavement, maybe you may be having a class about grief and bereavement. So in that you can learn more about how we do the bereavement supports and all. And you, normally the one which we do is emotional support. And recommendation for ES, it means education support. TA, it means travel aid and food kit. From Pallium India, we do these things. And also, if maybe one of the spouse is a patient, the other spouse is maybe not well educated, or maybe they don't know, they are like wondering about what to do in their life, we try to give them vocational training which can help them to, like, think about a sustainable income for the family. So these are the social support which we give to the patients in Pallium India. As already discussed, it's the educational support, food kit, vocational rehabilitation, and travel aid. So yeah. So hereby I am going to conclude my session. So as a part of conclusion, I would like to say is, like, in order to assess psychosocial and spiritual suffering, the most and the best assessment tool that we can ever have is to lend our ears to what they are trying to communicate with us. And when we when we listen, it's not. I believe that maybe I had learned about listening and hearing. Hearing means you are just hearing it. Maybe you may hear from here and you will leave it out from here. But listening means hearing it and understanding what that person is trying to say. So listen for hope versus fear. When the person, when that person will be talking to us, maybe we can understand, like, from their talk we can understand whether are they afraid about something, or do they fear something. We can understand that. Joy versus sadness, what are the joys that they have, or what they want in their life, or what are the biggest uh, sadness or grief that they have in their life. Good memories versus missed opportunities. All these we try to listen and try to understand. So psychosocial and spiritual suffering is very real. though at times we tend to ignore it, but it's very real. And the most important thing is that unless we have a good rapport, I don't think that we will be able to recognize what their psychological or social sufferings are. So, if we can recognize it, I think we can be good. We can provide good care for the person. And also the other thing is like, as I already told you, psychosocial and spiritual suffering can be translated into physical complaints. So from vocational rehabilitation, what we try to do is that we try to stabilize the family's income, to encourage the family to become self-dependent. Maybe we may support for some time, but once they stand on their own feet, we'll tend to pull out our support, because we want them to be self-dependent and we want them to find out things for them. Then financial security of the family, that also we consider in vocational rehabilitation. And to engage the family, it's not that they're just getting a support from a particular source continuously, they are just getting it, but we make sure that the family is also engaged in to get support from others. So certain pictures I have shared, it's about what Palim India does: vegetable cultivation, cattle rearing, been provided to the patients over here, goat rearing, poultry farming. Also provide petty shops, stitching, shop on wheels, fish vending. So hereby I would like to conclude my session with a message from Cicely Saunders. Thank you so much.
Thank you, Lithin. So we have been going through psychosocial assessment of the patient, which includes psychological, social, financial, spiritual problems of the patient, and how to overcome, how to assess. Anybody want to ask any questions?
You can raise your hand if you want. Dr. Gaurav? Sir, can you unmute from... Yes, doctor, you can speak.
Just one aspect, a lot has been discussed today. Now, what I wanted to see is the spiritual aspect. Now, India is a largely spiritual country. Most of the societies and areas, we have a large prominent presence of some sort of temple, mosque, or church, or some religious organization. Now, also, I have seen in other places that there's some support from the religious part, like some church or something like that. But I feel in our community or in our country, this support isn't really much there. You see that almost all the homes will be having a altar, or they'll be having some place to pray, or some small temple. But the community as such, like every every household will be associated with some temple or church or some mosque or something. But I think this when the family is in trouble, I really don't see in our day-to-day practice or day-to-day lives that the help is not so forthcoming. We are not talking financial. We're just talking of like the spiritual aspect, which is like there should be someone like in a palliative care team. There are a number of people. There's a physician, there's a nurse, there's a social worker. I also feel that some religious aspects person should also be there. and because they will fill a void which the others cannot. A doctor or nurse cannot discuss
Yes.
religious or spiritual things with. They will not be so forthcoming. So initially, if the family was involved with some previous religious organization or some place of worship, I think that could be a lot helpful, because everyone has got only that much time to give to the patient. So that I feel is very much lacking. And secondly, what also I have seen, I always go through a lot of these courses and literature in the more developed Western countries. What they do is, when the patient is fit and fine, walking, talking, carrying out daily activities, we today what you've discussed is very extensive. So many aspects are there. So what they do is, from day one, they know this patient might not be cured. They know this patient will go under a very prolonged treatment. So from day one, what they do, they incorporate all the aspects of palliative care. Some of the patients which we see in their cases, doctors advise this family of this patient is getting palliative care. But the fact is, they have fought for the case 1.5 to 2 years in advance. And usually what we see is patients who are bedridden, on the stretcher, who are bed-bound, homebound, they have lost all the finances. So I think these two aspects, one is this spirituality aspect, where the community or the religious aspect has to come forward, and second is the palliative care has to come in very, very early, in contrast to what is happening currently in our country or in our community. These two, it will help a lot. It will help them decide, like we're talking about the finances. Now, if we have 2 children and have already spent 15 lakhs, and after 8 months, then I think, oh, now I don't have money for treatment, and now I don't have money for this children's education. So it won't really help. I think these two things should be done.
Yes.
Thank you, Dr. Gaurav. Lithin, any have comments?
Actually, for like whenever a patient comes to our care, so we have already we work as a multidisciplinary team. So as Dr. Gaurav has said already, so we try to know, if we tend to know that first of all, we try to understand if any spiritual suffering that person is going through. We'll try to incorporate a priest or like whatever denomination they are from. We'll try to incorporate them too, because if that can enhance their quality of life, that is what that's what we also want, right? So we try to do that. Yeah, same thing. Say something.
Anyone wishes to speak? Dr. Anshika?
Good afternoon, everybody. It was a very nice presentation. Thank you. You mentioned about when the patient is diagnosed or is told about life-limiting illness, and they sort of go into a bit of anxiety, depression, and have these feelings of probably suicidal feelings. You also mentioned that you have come across situations where the whole family wants to, whole family feels they have nothing better to do but commit suicide and mass suicide. So how often in your experience have you come across situations like this?
Actually, once we had such a thing which had happened, where like a mother and a daughter was staying together. I think the mother wasn't well, so they tried to seek the support of the community. It's been like a long time back, so but they didn't get any support, neither from the neighbors or from their communities, nor from any like palliative care agencies or any other health institutes also. So finally, one day what happened is, like the door was like closed for like like I think it's been like 2 to 3 days. The door was closed for some time. So people tend to know. Always we see that mother sitting outside, but today what happened? From 2 3 days we are not seeing. So when they just opened the door, they saw that both of them are like They have hung themselves. And there is a note which the doctor had written was that we try to seek support from everybody, but nobody gave us that support. So thank you for everything. We are going from this way. So that was quite challenging. It was it's an incident which had happened in Kerala. So there are times when it happens, but mostly if we tend to know that somebody is going through this trouble, we try to reach out to them and provide maximum support to them, which would not further lead them on to commit something like this. It's not much, but it does happen.
So you also mentioned about vocational rehabilitation as part of psychosocial support.
Yeah.
So I wanted to, I don't know if you mentioned in between, I went offline, regarding the kids of the family, the children of the family. So are we at Pallium India, do you have a program to provide them, make sure that they are continuing their school education and food packets and nutrition? So can you elaborate about that?
Yes. Yeah, we do provide the education support to the patients. We, after the assessment, when we understand their problems, we try to provide the education support to the family, also as well as if their socioeconomic status is quite low. So in the socioeconomic sheet itself, we have like 4 columns, like it's very poor, poor, and middle income and high income. So in that, if we tend to know that the patient is having a yellow ration card, not just like that, maybe having, and there is no other breadwinner in the family. They don't have any source of income unless they get back to a system. Maybe the spouse can be trained enough to find out a source for them. So till that, we do provide food kit for them, and also we don't keep up a time for them unless they are able to provide for themselves. We do provide the food kit for them. It's continuous.
Thank you.
Thank you, Doctor.
So here we have a postgraduate student from psychiatry department who has been with us for past 1 month. So we will ask him what was his experience regarding psychosocial aspects of the patient, and as you told, how prevalent it is, and how much depression is there. So I would like Joe to speak.
Good afternoon. My name is Dr. Joe Sunny. I am a junior resident, third year junior resident from Trivandrum Medical College. It's a nearby institute. We are posted here for 1 month as a part of our training. One thing, since the topic today is psychosocial assessment and the psychosocial factors, one thing I have to emphasize is, as Mr. Lithin had emphasized, listening. From that, one more term should be added: reflective listening. Sometimes when we listen to the patients sometimes ask us, "Why are you just listening?" They will ask us, "Don't you have any advice to give us? Don't you have anything to say to us?" We shouldn't make them say that. We should be listening, and even when listening, our facial expressions should be speaking to them. Sometimes a minor expression like "oh," and when they say something very significant, we can paraphrase it. For example, if a person was saying that എൻ്റെ അച്ഛൻ മരിച്ചതിന് ശേഷം എനിക്ക് ഭയങ്കര വിഷമമായിരുന്നു, and he pauses and sorry for my Malayalam. When the patient says, my father had died last week and I was very sad for 1 week, and he pauses and he tears up, we can just wait for him to cry. That may help him. And after that, that you were sad, and all that we can again paraphrase. And that is one important thing, reflective listening. And next to the other part, one sir has said about the children. We always look at the social factors and we look at the educational and other factors for the children. But I think sometimes the emotional factors of the children are left behind. We had it during my sir had asked me to say the experience here. During my experience here, almost it is 1 month. There was a patient. I'm not revealing her name. Her son was whispered to everybody. He was walking around. He was talking to everybody. But the problem is, we all felt about the educational need. We tried to educate him, we tried to teach him, but we never asked whether he had any emotional problems. We don't have to ask him whether he had any emotional problems. We just want, it was just needed to give him some time. He would say it. The problem is we always tend to teach him, we always tend to go into the factors which we want him to do, but he wanted something else, something else. But he was ready to talk, but always we talked to him. We weren't able to listen. Listening empathetically and reflectively was very important. I think that should be incorporated in every case, especially in children. So for children, usually they will say what they want. Adults usually are reluctant to ask some things, but children are not reluctant. They just listen. I think what Mr. Lithin had emphasized is something I also had to say. Listen, listen, and listen. That is the best lesson that we can get from this class. And I had a wonderful experience at Talim, India. And what I was able to do was, since I am a postgraduate student in psychiatry, I was able to assist some patients and also to treat some patients. Also, I learned what palliative care means, and I understood every patient, even when, as Rajagopal sir says, if the patient is having what usually sir says, palliative care is supporting everybody with suffering, helping everybody with the suffering. And then I think in my department also I can do that, because almost every one of our patients is suffering. And I learned it from this institute. And I wish everybody who is listening now will be able to do this after the course and after the your association with Pali Media. Thank you.
So can you also speak about your experience of depression in patients with palliative care? Because that we don't have any class on that. So it will be better because depression is an underdiagnosed thing in many patients. So
depression,
you can speak about your experience, whether you have seen any patients with depression, where you was it needed to start some medication, or was psychological support was the only thing that was necessary?
This is what sir has asked me is a very important aspect, because one thing in palliative care, we usually have a confusion whether the patient has grief, whether the patient has normal sadness, or whether the patient has depression. Depressive disorder is a disorder. It should be treated whether by drugs or by psychological means. But grief, it needs support, but it is not a disorder. That is not a psychiatric disorder. But the problem is the line is very thin. When we say, my father died yesterday and I am sad for 2 days, that may be grief. But that may be grief. And if I attempt the suicide today, just 2 days after my father's death, then I should consider the fact of a depressive disorder. Depressive disorder usually is diagnosed when it is at least 2 weeks, duration 2 weeks. But the problem is, I had the symptoms only for 2 days, but I attempted suicide, which was a very lethal attempt. I attempted hanging. Then I should have the suspicion of depression in my mind. The problem is, to have a class on depression, I think it should be, I am suggesting sir to have a class solely on psychiatric disorders, because that is a very important thing. And even when I say I have a limitation of time, that's why I'm not going to the details. But one thing I'm saying is to detect depression is very important. And if it is depression itself, in mild to moderate cases, we can help with psychosocial support. Psychosocial support, usually in our terms, we say about cognitive behavioral therapy and very difficult words and difficult therapies there. But I think everyone who's listening here can do one thing, which I said earlier. A person with depression, he wants us to listen. Sometimes they say, go, I don't want to hear anything. But I am clearly stating it, they always want us to listen. And reflective listening is one thing we all can do. That itself is a form of supportive psychotherapy. And that is something we can all do. That is one major point that I have to emphasize. And from my experience here, some of the patients was given medication by me. Though I tried supportive psychotherapy that I had talked to you. I didn't go into the specific form of therapies. I tried a supportive method, and then I started them on medications. One thing was, one patient, he was a 45-year-old 45-year-old male. He was diagnosed with uh, uh, I think it was a carcinoma in the intestine, and also he had intestinal obstruction. And he was in his end stage. Even then, while talking with him, I had a suspicion of depression. But there, that thin line was there. I didn't know whether it was an adjustment issue or whether it was depression. But I started him on a medication, which is mirtazapine, because his symptoms was he wasn't sleeping for he said he didn't get at least 1 hour sleep, and he said he wanted to sleep somehow. And I tried my supportive way, but that was not improving his sleep. And I knew one thing: if his sleep was increased in his terminal days, that will improve his quality of life. And next thing was, he was saying that he had multiple gastric symptoms, and the medication that I gave, it had a 5-HT3 antagonism, which was similar to Emicet, that is ondansetron. So I gave him that medication, even though the diagnosis of depression wasn't clear there. That may have been an adjustment disorder. But even then, I just gave him that medication that helped him. Sometimes we have to weigh between the risks and benefits. There, the benefit was surely high, so I gave him that medication, and I saw that he started sleeping better. Though his symptoms were worsening, he started sleeping better, and that at least that would have helped him in his improving his quality of life. That is one patient, and there were multiple others who had betterment on medications and also with the supportive care. But in some cases, medication is required, especially when the depression is moderate to severe.
Thank you, Joe. Dr. Anshika.
Sir, you mentioned about how common is anxiety or depression or psychosocial symptoms in cancer patients. So, in fact, when I started my association with Pallium India on the cancer-free, pain-free hospital initiative, so I took up a research project, and there I wanted to find out what is the prevalence of anxiety and depression in cancer patients. So we looked at 400 patients admitted with us in our cancer institute, and we used the hospital anxiety depression score. So that is a scale which has got 14 questions in English. It's validated for English scale, and it should be patient should fill it themselves. So I use the Hindi one as well for the Hindi speaking patients. And in these 400 admitted patients, we found that the prevalence of anxiety was 25%. And the prevalence of, according to the score, the abnormal score, not even the moderate, but the abnormal score. And the depression, the score was abnormal in around 22 to 23% of the patients. So this is what we found. Then we wanted to know, this is the admitted patients. What about the OPD? So we did this study again. Another one of our medical students did it as ICMR project, and the same project she did on OPD patients, and she found that rate to be around more than 30%. The prevalence, it's around 35%. So this study, in fact, the one which I did in admitted patients, we have given it for publication in Indian Journal of Palliative Care, and it's accepted and going to come soon. I'll put it in the group when it comes. So when I was looking at the literature search for this, so of course, people have used hospital anxiety and depression scoring system only for just as a screening tool. It should not be used to diagnose. Now, if you do have an abnormal score, ideally we have to refer to a psychiatrist or take somebody's help who is going to help the patient correctly that way. Other thing is, we found that there is no prospective data in India. A lot of prospective data is missing. All have been the retrospective analysis of the data of the palliative patients visiting the OPD or were admitted. But when we look at the West, they do have prospective data. So we have to, as a psychiatrist, probably one should, maybe you could take up these projects later as well. That how many patients, like as you can help more with the depression and anxiety, prospectively, how many of them do develop anxiety, depression?
You raised was a very pertinent question, because I didn't talk about the prevalence, because the prevalence studies show, as you have, if you have gone through, you will have seen the rates they given multiple papers are very different and very varied. Some say very high prevalence rate, some say varied ones, because one reason is what you said. Hospital anxiety depression scales takes the anxiety symptoms only, and the other studies say about anxiety disorders, and some says about the depressive disorders. Both are different. Depressive symptoms will not be fully qualifying the depression criteria. That is the problem. So it is better not to say a specific number. That is why I didn't say that, because especially in India, the studies say different rates in different studies. As you said, I think we as psychiatrists, our department and I should be doing something, and I think our department is doing a project in Pallium, India, and we are planning to do a study on this, and we have given it for approval in the ethics committee here in the medical college. Okay, and thank you, madam, for your insight.
Anybody else? Okay. I think it is most important. Most important thing is that we should be more aware that there is a more prevalence of anxiety and depression in palliative care patients, and the prevalence rate may be variable. But I read that the prevalence of incidence, I think the major depressive disorder is 21 to 22% in palliative care patients. So it is mostly not diagnosed, because many of us don't know how to diagnose depression. What are the criteria to diagnose depression? The only thing is that we should be more aware about depressive symptoms, so that whenever we have a doubt, we can refer the patient to a psychiatrist or can get help from somebody. And once we make a diagnosis, we can help the patient, and even we can help the patient from suicide. We will move on to the patient story now. Dr. Patna will be presenting patient story. Dr. Patna is a family physician and the professor of pharmacology. She is from Bangalore.
Padma, can you hear us?
Yeah. Can you hear me?
Yes, doctor, you can start.
Hello?
Yes, doctor, we can.
Hello, can you hear me?
Yes.
Yeah. You can hear me?
Yes, doctor, we can hear you.
Hello? Yeah. Good evening to one and all. I'm Dr. Padma from Bangalore, who is a family obstetrician, geriatrician, as well as professor of pharmacology in one of the medical colleges in Bangalore. I have a patient who was quite old and from Coorg, and she was about 70 years old.
I think we have lost her. We can wait for a couple of minutes.
Good.
Dr. Padma, can you hear us?
No, should connect. Hello?
Hello, doctor, can you hear us?
Yeah. Can you hear me?
Yes, we can.
Yeah. Can you hear me?
Yes, doctor, we can.
So this was a case where it was from non-cancerous to cancerous condition, and the diagnosis, she had already had a hip fracture when I met her, and later on she developed a breast carcinoma with calcification after about 2 years. The presenting complaints were she was a lady of 70 years who was very fragile and emaciated, not able to hear, and she was a known mild diabetic and was hello.
Hello, Dr. Padma. Yeah, please speak.
Hello.
Yes, we can.
Sir, shall I start?
Yes, you can.
Yeah. This lady, yeah. This lady who was 20 years, who was fragile, emaciated, not able to hear, was a known diabetic and was constrained to the house. And I had started seeing her since 2014. And 2 years later, by about 2016, she presented with oozing in the left breast, initially with plain serum, and later on bleeding, and it was quite painful. But she could not express and only squeeze the face. Because she was not talking at all, she used to just keep quiet throughout the day, and she used to make some signs for eating, drinking, or taking to toilet. But later on, she could not be taken to toilet also, so she was almost in a bedridden state, and she was unable to walk, and it was hello. On examination, hello.
Yes, doctor, you can continue.
Hello. Hello.
Yes, doctor, we can hear you.
Hello. Yeah. On examination, there was a tender left leg because of the fracture, where we could not go for the treatment. And on the left breast, it was about 4 into 5 centimeters open oozing wound, where it was tender and also inflamed. No other clinical, otherwise normal. We got some investigations calling the technician to the house itself. Then we got the report, except for her mild diabetic, and the x-ray showed that old fracture. Hello. Hello.
Yes, please continue.
Shall I continue?
Yes, doctor.
Regarding the psychosocial aspects, the patient was cool, sitting in one sofa throughout the day, or she would be made lie down. But the daughter was quite apprehensive because of all the conditions like socio-economic, financial, everything. So we had to counsel the daughter more than the patient here. And I had hello,
Yes,
hello,
yes, please continue.
hello, hello.
Please continue, please continue.
We had to counsel the daughter more than the patient because to look after socio-economic aspects, financial aspects, everything. And I used to do it personally because it was they also has and I also used to go every 15 days to their house, spend about an hour and counsel the patient or the patient's daughter, look after the patient and tell them whatever is needed and other things. Regarding the medication, constipation was the main problem with that patient, and so we had prescribed Dulcolax and glycerin suppositories, and medical nutrition therapy was given. A home-based therapy was given, and she used to encounter recurrent UTI. Though she was not on any catheter and other things, she was having recurrent UTI. And diabetic medications, we had given only insulin, Mixtard 606 units, where it used to control, and the blood sugars were between about 120 to 180 maintaining, so there was no other problems with some B complex and other things. The other medications were paracetamol. Because of her age, we had reduced it to 250 milligrams 4 to 5 times daily, and sometimes if the pain would not get controlled, we had diclofenac patch where we used to apply it one or twice a week or thrice a week. Then later on, as and when she started having that pain and squeezing, not able to sleep and all those things, then we started with fentanyl patches twice a week, and local wound dressing. Because it was oozing, we used powder, and so the oozing would not go to the other places and hence restrict, so that there was no spreading of the wound. And later on, we also added polymyxin, so thinking that some of the gram negative problems also would start. So we also did this, and somehow we used to do a nice dressing where it was the wound was little wet also, and hence we controlled it likewise for about 2 years. And the patient was totally bedridden. Then later on, when we consulted one of the oncologists, we had to choose this metronomic chemotherapy, where she was put on low dose methotrexate continuously and twice a week, and also folic acid 5 milligrams daily. Now the main concern was, because she was aged also, we wanted to give a good quality of life, where the daughter was very particular and she looked after day in and day out sitting next to her. And prevention of bed sores, which the daughter did it very effectively. There was no bed sores at all till her death. And to decrease pain, we almost had almost all non-steroidal anti-inflammatory drugs as well as opioid analgesics. And to decrease lymphedema, we didn't have any other options except to keep the hand and the arm at a higher level, keeping some 2-3 pillows and other things. When she was sitting, it was a little of concern, because under the gravity it used to really become very thick, and she used to squeeze her face with pain, so that we used to make her lie down so that this edema would decrease as and when we really encountered these phenomena. So in a summary, I can say that this lady was diagnosed from a non-cancerous palliative care to a cancerous palliative care, where financially they could not afford, they would not go anywhere else. So we had to take home palliative care itself, and I think we have done it effectively till our demise, and even the daughter has accepted this very gracefully. Thank you very much. And the discussion, I think it's mainly on pain, constipation, and the psychosocial activity, because today's is the main topic is that I think we had to do it for the daughter rather than the patient. Thank you. Thank you.
Thank you, madam, for this interesting patient story. So, it's a 70-year-old woman who has
Yeah.
carcinoma of the breast and who had fractured her hip previously. And she was receiving metronomic chemotherapy. So I think one of the questions from Dr. Patna was metronomic chemotherapy. So we are not experts in discussing metronomic chemotherapy, but either Dr. Gaurav, can you just tell us what is metronomic chemotherapy in short?
Yeah, hello. Metronomic therapy is basically when we are not able to give the correct standard of care in chemotherapy practice and at proper doses, then it is known as metronomic therapy. Metronomic therapy is basically if you can't give something, you give something. If the patient can still tolerate that, taking into account that the side effects will be there. Here, basically, she received metronomic methotrexate as well as folic acid. So this is one of the commonest regimen which you see even in head neck cancers, and here it was given in breast cancer. So I think that's fine. It's because the side effects would be basically it would affect the hematologic indices, but I think that could still be managed quite well. So for this patient, I think that's fine. The only problem is, actually, I should really commend doctor because she's been managing this patient for the last 2 years, and later on this breast thing came up. So I think she's followed up very rigorously and thoroughly. That's quite a good job. I think very few people get this opportunity to follow up such patients for such long time. And I think that right now, I think things look quite good for her. And metronomic therapy should only be continued in such time that the benefit is it is outweighing the side effects. But the moment when she see that she develops mucositis or she requires repeated transfusions or she is becoming too weak, then I think we can always withdraw from the metronomic therapy.
Dr. Gaurav, do you think the fracture of hip, is there a possibility that it was a metastasis pathological fracture?
If you look at the timeline, what doctor has said, I think that there was a 2-year gap since she had this fracture and the development of the breast ulcer. So I think if an indolent breast cancer is there, there is always there's a chance that it could throw an initial metastasis to the bone, to the hip bone or to the femur, and that could possibly have caused fracture. Hello?
Yes, Dr. Gaurav, please continue.
Yeah. So, and later on, when the tumor started increasing more, then only she developed that breast ulcer, which started fungating and caused her all of the physical pain and discomfort. So that's always the possibility. But a 70-year-old patient with metastasis to the to the femur, causing a fracture, I think very few oncologists would be willing to take her up for any sort of active treatment. Even then, she would be on palliative radiation to the fracture site to help with the healing. And I think orthopedician opinion, I know that she does not have much of a comorbidity. She has a few, but I think that at outset, if we could have taken the help of an orthopedician to fix that leg, possibly it could have added something to her quality of life. But other than that, even then the palliative chemotherapy would have been there. But it's a difficult call to, frankly speaking, it's a difficult call to retrospectively judge if she had that. But I think that fixation could have helped her a lot, even if it was malignant or non-malignant, if possible at all.
Okay. Thank you.
Sir? Hello?
Yes, Dr. Patna.
Hello. See, she didn't have metastasis. It was first hip fracture. And later on, after 2-3 years, she developed that breast problem. So it was not a case of breast cancer going on for metastasis.
Yeah, I totally, I know it's retrospectively we really cannot pinpoint, but I think that you must have done when you taken the patient, taken care. the last 2-3 years, I think this would have come up at some point. Some of the indices
Yeah.
would have popped up, shown up in the charts, or somewhere symptom would have been there. So it's
Yeah.
always possible that she could have developed the breast cancer later. But the other aspect which I was saying, that if possible, for financial or practical aspects, if you could have just put a
Yeah.
nail, put some sort of a fixation for that leg, then it could possibly have helped. That's all I'm saying.
No, they could not do all those things. So we just moved the problem just like that for about 2-3 years. And last about 6 months back, she passed away.
Okay. So no, I think really
Hello?
it's quite a good job. I think you've done with the patient.
Dr.
Thank you.
Can you elaborate on the pain of this patient? Where was it? How was it?
Sir, actually, no, pain was general actually with her. So
Okay.
she used to only squeeze the face whenever we touched around the breast area as well as around the hip area. She would squeeze with pain. She would not speak at all. I think she had decided that she would not speak. The voice was there; she could scream and do all those things, but she would never speak at all. And she used to keep calm, cool. Whatever we asked, she used to just nod her head. So that was the problem. So amount, we gauged it and started with all these drugs. So that was the type of pain what she experienced and how we felt. Whatever we felt, we started trying with initially paracetamol, then diclofenac patch. So I tried with always non-steroid, non-NSAIDs only. But later on, she could not sleep, no. So for that, we thought we will put twice a week or once a week fentanyl patches. And some of the times it would be monthly, once or twice, that's all. So she could bear the pain, I think so. She was not very this one. So this is how we managed pain with her. And I didn't give any injections or IV drips. No, we did not give any of those things because she would take everything normally and she was given a very soft diet. The doctor looked after very well, almost about 100 to 200 ml every 3 hours, so that she was kept very hydrated and nice.
Okay. This patient even was not speaking to her daughter also?
No. Used to go almost full 1 week continuously, sir. She would just see us, laugh, and she used to squeeze her face, not even shrug her shoulders also.
Okay. So, uh, do you have morphine with you, or or only
No,
having?
sir, I don't have morphine. But I get fentanyl patches from a distributor.
Okay. So, can you tell us what was the strength of fentanyl patch you applied?
That 25 micrograms to 50.
Okay. So, how was how was the pain during that time when you applied the patch?
She was very comfortable.
So,
But most often I used to use this diclofenac patches only, sir.
okay. So, diclofenac patches. What is the duration of action of these patches?
24 hours.
Okay. Dosage?
Dosage is about 50 milligrams.
Okay. So, you have to apply once and it will work for 24 hours.
Yes, sir.
Okay. Any others are using diclofenac patches?
Yes, sir. All these dental people know.
Yeah.
When they get this extraction, and most of them will complain of gastritis and all those things. They have started, and I teach all PG students of MD as well as MDS students. So in all those classes, I used to mention all these things, and most of them nowadays, it has spread like a message, and many of them are using diclofenac patches, especially after dental extraction. And those who have got gastritis and they complain of pain, these people are also using diclofenac patches for about 3 days maximum, where otherwise they had to take this diclofenac 2 times daily for about 3 to 5 days. So that will reduce their gastritis, and also this Pantodac tablets or even domperidone, whatever it is, all these will decrease, and so patients are very comfortable.
Okay, Dr. Anshika want to speak.
Yeah.
Anshika, please.
Sir, we have regularly used diclofenac. Am I audible, sir?
Yes, yes, sure.
Am I audible? So we have regularly used diclofenac patch in our practice, even in surgical practice, as ma'am was mentioning, any kind of surgery, even in palliative care. In some patients, we use, especially, let me just discuss about in patients with palliative care. Some of them are not able to take orally, and we find a specific indication where NSAIDs are required. So we do give these diclofenac patches, and the common company name is NU patch. And I'm using 200 mg dosage as well. And usually it works for 72 hours, and it's very cheap, quite cheap. And so it does work very well. But only patients I'm using where I cannot give oral diclofenac or oral NSAIDs.
Okay. Okay, we are not very much experienced with diclofenac patches, even though oral diclofenac is available. Why, if that fentanyl patch was given good pain relief, why it was not continued and it was used occasionally?
Because we used to see we used to experience about the pain. The daughter would call me. That particular day, she was not very comfortable. She was not eating. She was not cooperating, and all those. So in that way, we used to judge it and see that we wanted her to make more comfortable. So that's why we started using only whenever she required, and we felt that she's in total discomfort. Otherwise, we used to stick on to these paracetamol and diclofenac patches.
Okay. I just want to tell you that I know that morphine is not available for you, but when you apply a fentanyl patch, it will release only the constant amount of fentanyl into the bloodstream. So if you apply 25 microgram, it is
Yes,
going to be only 25 microgram. You can't alter the dose. So that's the problem with patches. So if morphine tablet or some other opioids which are instant release if available, it was good to start with yeah those opioids, so that we can have an idea about how much dosage of opioids she require, and then we convert the patient onto fentanyl patch if the pain is stable. That's what usually done.
Yeah. Yeah.
Okay.
Correct, sir. Correct, sir. I agree with you.
Yeah, thank you. What was the reason for constipation in this patient?
I felt she would not eat properly. So she shifted on only to liquids, and once it so happened that we had to take it out through our gloved finger. There was impaction also.
Yeah.
So all those things we started doing in the house itself. We didn't take her anywhere.
Okay. So can somebody tell us what were the causes of constipation in this patient? What are the possibilities? A 70-year-old lady who is mostly bedridden on some medications, complaining of constipation. What would be the causes of constipation?
No, she was not on any other medication, sir.
Yeah. Okay. Dr. Gaurav.
We can see there are a number of causes which could be here. First is the age. Whether or not she's patient on palliative care, she's a normal 70-year-old lady, it is bound that she'll constipate. Secondly, she's bedbound most of the time. Thirdly, the oral intake, the hydration status is possibly not up to the mark. Fourthly, she's already on fentanyl, an opioid. That's going to cause constipation. So all of this, plus she has this fracture, and that won't help her in normal defecation. So that again would cause constipation. So we see there are a number of points, a number of reasons why this patient is bound to be constipated, especially with the pain of such intensity as a fracture neck humor can cause. No one would actually want to move their fractured hip with the fractured femur. So obviously, cause of pain itself, that could be an inhibitory cause, causing her to not pass through the regulator. So that is why she's having this fecal impaction and so.
Okay. Thank you, Dr. Gaurav. Dr. Patna, was she completely bedridden?
Yes, sir.
Okay.
Later on, she was bedridden.
Okay.
Initially, we could lift her and put her on a sofa.
Okay. There are many causes, as Dr. Gaurav told. So the mobility is decreased, so that the action of the muscles are also decreased. The peristalsis will be decreased. And because of the pain, she is unable to move her legs, so that the normal position she used to pass motion is also lost, which can also cause constipation. So there are many causes which can cause constipation in this patient. So what should be the management in this patient?
That's what I used to do, sir. Initially, they themselves had taken Crimapin and other things, but I preferred suppositories. And later on, I thought of enema, proctocetyl enema, but she was very comfortable with Dalcolax or glycerin suppositories, which we used to use it 5 days, once in 5 days or once a week. That would give her a lot of comfort, and I didn't think that that should be given every day where we had some sort of laxative misuse or anything like that. So with once a week or 5 days once, it was comfortable, so we went on.
Okay. This patient constipation can be managed both non-pharmacologically as well as pharmacologically. And this patient,
Yes, sir.
non-pharmacological management like hydration or asking to eat more food will be very difficult, because already we'll be having loss of appetite because of many
Yeah.
reasons like old age as well as advanced malignancy. Pharmacological things will be difficult in this patient. So pharmacological management would be the thing that we need to give in this patient. As she told, suppositories or enema would be good for this patient. And whether oral laxatives is also advisable, which can also be tried if with oral laxatives, if the patient is passing motion, then we need not do any parenteral interventions.
Yes, sir.
Anybody else wants to comment on this patient? Dr. Gaurav.
I had one question. If we can go back to the chart of the medication which was. Yeah, paracetamol 250 milligram. I'm not really sure. Like, why 250? She was
Because
hepatic.
of age. Because of age.
Yeah, Dr. Gaurav, in old age, the suggested dose of paracetamol is up to 2 grams per day.
So, but even then, it's hardly a gram. 250. I don't know if we
Yeah,
can
yeah, we can go up to 2 grams per
up to
day.
2 grams. And another thing was when she was taking something per orally, and things that could we have tried with tramadol initially before putting the patch? Because for instant,
Tramadol might have caused vomiting. And she was very lean. So for all these reasons, I thought tramadol is not a good choice.
Okay, so and this patient, as you told, we can try with tramadol. As you know, all the opioids can cause nausea and vomiting at the start of any opioid when you introduce it for the first time. So maybe you could have started with metoclopramide along with tramadol, which can prevent nausea and vomiting. So that's one option. Yeah. Dr. Anshika?
So, do we have time to talk about lymphedema management
Oh,
in this patient? I think
I
it's
think
already
that's
4:30.
important.
Yeah. Yes.
So
She had
I think,
lymphedema.
yeah. I think in lymphedema, yeah, she was only, what was the treatment she was getting, Dr. Patna, for lymphedema?
No, we could not do anything for that, sir. I used to give some Chimerol Forte or hyaluronidase, that's all. Apart from that, I used to ask them for some stockings so that the whole pressure would not be there. That's all we did. We did not do anything else regarding that.
Okay, so for basic things which we need to do in lymphedema is skin care. So we should keep the skin moist.
Yeah,
Um,
yeah. Skin was good,
to
sir.
the
Skin was good.
dryness. Then there are some certain principles, general principles, like you should not take blood pressure, or you should not inject
Yeah.
anything on the lymphedema TSAM, and
Yes.
avoid mosquito bite and things like that has to be avoided. Should not wear tight clothes, should not wear rings. All these things are coming under general lymphedema care.
Oh,
And
yes.
then there is the skincare like moisturizing, then massaging, which is a gentle massage, not the massage which the traditional people, traditional healthcare people do. It's a gentle massage of the affected arm from the distal to proximal end. So before doing a lymphedema massage on the affected arm, you should stimulate the lymph nodes on the opposite side, so that the lymph fluid will drain from the affected side to the unaffected side. Uh, so lymphedema massage is there. Then there is some compression bandaging. The compression bandaging need to be done from the palm to the shoulder. Then once we reduce the once we reduce the edema of the upper limb, then you can use stockings to maintain that. But the one thing is that you have to continue the lymphedema massage every day. Then only the edema will come down. Otherwise, what usually patients will do, they will do the lymphedema massage and care for maybe 1 or 2 weeks or 3 weeks or 4 weeks. Then the lymphedema will be decreased, and then they will stop all the things altogether. So that will again cause recurring lymphedema. So it should not be done. So the basics are general principles of skin care, lymphedema massage, and then lymphedema bandage. And I think we will talk on lymphedema if possible on another class during one of the patient story. And if possible, we will also show you a video regarding how to do a massage and how bandaging can be done. Okay.
So we are logging off for today. So see you all on next Friday with a topic on delirium taken by Dr. Rajasri. So thank you all for joining in. See you later. Bye.